So when I say rural, that means those who are not practicing in metropolis areas. What difference do you find in the medical practice in the cities and in rural areas?
It is a direct communication with the patient.
Right.
Today, patients come down.
And of the 150, we are seeing more and more strokes coming in the younger age group between 25 and 45. So, even you are treating heart attacks more than the brain stroke. Do you think that incidence of these heart attacks are going up in youngsters?
Since diabetes is a silent killer, doesn't produce any symptoms. Just change in diet can bring sugars down by 40%. The reduction in sugar without any medicine can go up to 40 to 50%.
Okay,
Not 40 to 50 milligram percent. So that is a tremendous
Very
source of the correct diet.
I mean, for a mobile, if I'm buying iPhone, which is about 1 lakh rupees, or any other smartphone, I buy insurance.
Chelation therapy is giving EDTA intravenously.
Vijay, आज आपण we are going to discuss about a scenario of brain stroke in rural areas.
Right.
So when I say rural, that means those who are not practicing in metropolis areas, like say Bombay, Nagpur, Pune, those areas. So by definition, when we say rural areas, we include all those areas which are beyond the boundaries of metropolis.
Okay.
Because the pattern of practice is distinctly different in these two areas.
Very true.
Though the difference in the medical practice standards or infrastructure are closing day by day, but still it is far from reach for the normal people, when you go to the rural medical practice. And in fact, it's something that I must really congratulate you, because we both have come from the same college. We both for the before medical and medical colleges, we both have passed out in the same college and hospital. But you preferred to go back to rural India to give services to people there. That is something which is very, very commendable. I must really congratulate you, because we all try to stick to these cities for the want of better infrastructure, for want of maybe better patient load, or maybe for the want of being having little more luxury in the lifestyle. Prefer to stay back in these cities. But you are the one who, though you had a chance to settle down in cities, you prefer to go to the people area. That is one thing which I must really congratulate you. And being a very long association of ours in almost 1974 onwards.
Right.
Yeah, 1973, 1974, we entered together at Ruparel College.
75.
Yeah, in that time. I think you have been an excellent academician even during the pre-medical and the medical school. And in your comparison, we were the duffers. And that may be one of the reasons why actually we decided to settle down in the cities and you went to the rural areas. Anyway, many congratulations for that. And that's the reason that we have invited you to say a few words about the pattern of medical practice, the differences in the medical practice, and how actually you cope up with such a different practice, because it is not something a simple person can do. It's very, very difficult. But there are too many shortcomings when you treat a patient in the peripheries. There is no question about that. So, the first question which I want to, which is very, very general, in the saying that, what difference do you find in the medical practice in the cities and in rural areas?
Right, Ashok. Nice to talk to you today. See, when you talk about metropolitan city and rural area, now you have tier 1, tier 2, tier 3, 4. So I would label this, my place, as a tier 4 city. So it's as you are cutting off from metropolitan to the rest of the things. This is not actual rural area, so to say. These are not villages. This must be population of between 5 lakhs to 10 lakhs. And over years, this has rapidly developed. And what I would say is that the infrastructure as well as facilities have developed so fast. So just to tell you, if there is a McDonald's, if there is Vamanari Pete or big jewelers, and your all those malls and people moving in Mercedes and BMW, it is as good as a small city.
Small city. But when you actually reached Amarnath
Yeah,
for the practice, that time there must be just villages, right?
right. And that is a very interesting story to
Yeah.
tell you.
Yeah.
1989, see, after finishing my MBBS and MD from KM, I went to Nair Hospital as a lecturer. So almost 2 years I worked in it, MAKU, that is acute care
Medical.
unit.
Yes. Yeah.
And thereafter, there was an opportunity to me that advertised saying that you have medical officer's post and private practice is allowed, and they had offered me a good residence. Frankly, I didn't have a residence. I wanted to get married also. So I thought this is a good opportunity. I have a good 3 BHK flat to stay very near to station, and only 5 hours of practice, and rest of the time I was allowed to do practice. So actually because of that I went there.
Okay.
Personally, frankly, it is not my dedication to serve in rural area as like Baba Amte or his son.
Why did you choose Amarnath of all the places? Did you have some ancestral property there?
This is single place where I applied.
Okay.
I was happy with lecture post, but then what I found was I was working in intensive care unit. The administration was not that fast to upgrade acute care unit to that level as expected. And then I thought, why not try my hands in a private practice where I can directly cater to people
Right.
and I'll be closer to them, whatever I learned so far.
Yes.
And Ambernath, that was the only ad I applied for. I went down for interview. I was immediately selected because probably I was overqualified for the post.
Right.
Frankly.
I'm sure you must be.
And then they wanted MBBS plus, so
Yeah.
were happy with me. And basically a physician. I saw the town. It was like a hill station. See, Ambernath, that in those days, 1989, was like a hill station. It's not a plain ground. There are hills and there are a lot of greeneries and greeneries. So I like the place. It was like going to Matheran.
Yeah.
And the stay which they had offered was also nice. And the locality was with some 500 bungalows. That time there are not many buildings.
Okay.
So I wanted a peaceful living, and I didn't want to travel everywhere. I didn't want the rush.
Yeah.
So I thought that I have some stable income. I will start my practice here and see if I'm not comfortable down the line. Probably I can again move back to the brand city. I was staying in Borivali that time.
Okay.
And from there to shift here, even my relatives were telling, "Oh, why are you going there when you have a lot of opportunities here?" Frankly, I had no money, and my father was not a doctor; he was a railway employee, and I didn't expect anything. It was good, and I was very thankful to him that he supported me till I passed my MD.
Right.
And I can be on my own. I was very confident about it. So that is the story.
Yeah. So the fate took you actually to Ambarnath. After 35 years of staying in practice, Ambarnath, do you repent your decision?
Frankly, no, I am not repenting.
You are not repenting. So you are not finding any deficiencies of staying in that place for such a long time.
Maybe there is a difference as far as the money part is concerned. But then it depends on individuals. See, I was very happy when I was drawing 4,000 salaries in 1989 and probably slightly more here in private practice. And today also I'm equally happy.
Yeah.
Whether I go by walking or by auto rickshaw or if I drive Mercedes, it doesn't make any difference.
Different.
Internally, I'm happy.
Yeah, I think the perks of staying in Amarnath are much higher than what you probably would have in city. Yeah.
Right. As you are saying, see, you are talking about the infrastructure development. Today, we have CT scan center, which is nearby at 200 meters from my nursing home. We have whatever things which are required in emergency. We have cardiac ambulance. At Kalyan, we have bigger hospitals which are 100 bedded with most of the facilities which are available as good as they may not be at par with Hinduja or Mumbai Hospital or Apollo,
But well developed.
but then they are good enough to cater
Yeah, correct.
to the patients.
Correct.
So that the development has occurred over
Yeah.
a period.
So we want to say with infrastructure, even development medical also has gone parallelly very well into your areas.
Very
So that's why you're not finding any deficiency of, or any cause to repent of staying there
at the moment.
at the moment.
Years back, the situation was different. When I started, the things were difficult, and there were no big hospitals around, no 100-bedded hospitals with all facilities. So initial 15 years, I would say the things were not that they were difficult, but there was a pleasure of treating patient in. It is a direct communication with the patient.
Right.
Today, patients come down. Whatever happens, anybody getting chest pain will come down with chest pain to my ICCU and my small nursing home. I thrombolize patients, shift them for further management.
Yeah.
Many a times, I have saved patients. I'm in a nursing home. My nursing home is down on ground and first floor. I'm staying on second and third floor in duplex. So many a times I have come down running when patient has gone into arrest or brought in arrest. I have given DC shock and they have been revived. So I suppose there cannot be more pleasure than that. That somebody's life is saved.
Correct. No, it's really
I really enjoy that. And especially at night also when they come down, somebody's bad. At 2 a.m., 3 a.m., somebody's bad. I'll go down, see the patient. So they are getting directly somebody who's MD in medicine with years of experience. They are getting treatment immediately. Unlike some junior person seeing and then managing the patients.
No, it's really
So
definitely commendable. There's no question.
Yeah.
Now you have got one of the best ICUs in whole of Amarnath with 20 bed nursing home and well equipped ICU.
Yeah.
So that is good enough to treat the brain stroke and heart attacks. So in last 35 years of your practice, how many cases of brain stroke or heart attack you must be treating over a year? I don't want a exact number, but do you think over the years this number has gone up progressively? It has gone up.
when I compare with the heart attack, the number of strokes has not increased to that level, I would say. Patients with hypertension, diabetes, and heart attack have increased tremendously. Comparatively, the stroke proportion has not increased to that level. That's what I would say. Second thing, maybe I may be biased because most of the time I am known as a physician and cardiologist. So most of the chest patients or chest pain patients, they come to me. But at the same time, whatever number of stroke patients which are coming, they have not increased to that proportion.
Yeah.
That's what I would
Because
say.
the risk factors for both heart and the brain are the same.
True.
If heart attacks are going in number, I don't see any reason why the brain stroke also is not rising in number. Maybe as you said correctly that probably your picture or your projection as a cardiologist is much more than the neurologist. But I'm sure you must be hearing these numbers from your colleagues and stuff like that.
Right.
Because if you see the literature, the number of brain stroke, the incidence of brain stroke is definitely going up in the rural parts of any country, and the number which is quoted nowadays is something like 150 per lakh population. And of the 150, we are seeing more and more strokes coming in the younger age group between 25 and 45. So, even you're treating heart attacks more than the brain stroke. Do you think that incidence of these heart attacks are going up in youngsters?
Very true. Heart
Very
attack,
true.
yes. And I've seen heart attacks at the age of 26 years. And incidentally, there were two patients of the same age next to each other. Hey, there was a very big risk factor of tobacco chewing
Okay.
and
In both of them.
for both the patients.
Okay. Okay.
So these are the patients who land up in trouble very early.
Yeah.
And it is alarming proportion. And mainly it is, I would say, the junk food which is creating big problem. See, nowadays the younger generation between 20 to 30, I think more than 50%, they keep on eating on those Maggi and Pizza Hut and
Swiggies and whatever.
pizza with all that cheese burst.
Right.
They say cheese burst. One day I saw the cheese burst pizza and I said, I will try this and see. And next day my cholesterol increased by 40 milligram per se.
Oh my
From
God.
the earlier.
Just by eating one burger.
Yes. Only two slices, I would say, not the entire pizza also. I cannot eat an entire pizza. So it is very risky. And probably the oils which they use or that palm oil component, that is very dangerous, which all these youngsters don't realize. See, no doubt it is tasty. We also feel like having it. But then eating occasionally and eating very frequently, it makes a lot of difference.
It's lot of difference.
And all those Chinese serve with whatnot, Ajinomoto and all artificial colors. Then cold drinks they take. See, like some of the people that rather than water, I think they keep on drinking Pepsi or Coke. And very harmful.
Very harmful.
All our vessels are getting affected. So coronaries manifest more frequently, followed by your stroke. And it is very a matter of serious concern.
Serious concern.
That has to be changed. In fact, I would say all these wizards and these fast food shops or stalls, they should have restrictions.
Restrictions, which are not there at this
It is very, very dangerous.
So, when we began, you did not agree with me that rural is no more rural areas now. They're moving very close to city, or maybe you can call it 3-tier cities. So, with this kind of development, even the medical disease also progressed similarly in those areas, and that's why this defective lifestyle, unhealthy lifestyle is really taking over. And that's why we are seeing more and more case of brain and heart attacks now in the rural areas. So, in that aspect, I don't think there should be any doubt in the mind that even disease is spreading very fast with the development that is happening there. No? That is a good observation that you have. Now, I've been hearing from our common friends, I've been hearing from you as well. Your expertise and the research lies in treating diabetes. I mean, obviously you're treating everything, but I think your expertise mainly in diabetics. Now, how do you think the diabetes primarily affect any target organ, but mainly about brain and the heart? What is the mechanism? How does diabetes affect these organs?
Right. See, diabetes is a very bad disease. And as you said, from my primary thing of treating heart patients, I turned to diabetes because there is a story behind it. See, my elder brother, he had diabetes. He's no more now. He died at the age of 69 years because of a lot of complications related to diabetes. About more than 25 years back, he developed diabetes. And then within a year or two, he had heart attack.
Oh,
he had gone
fast,
into cardiac arrest. Yes.
Oh,
Cardiac arrest.
1 year after diagnosing diabetes, he had
Years after diagnosing that. And he had gone into cardiac arrest. Fortunately, he was not with me. He was staying at other place. He was revived. He came out of that. Over years, He was a very strong person compared to I am looking thin, but he was very strong and otherwise healthy for contracting diabetes. Slowly his health deteriorated and he didn't pay attention to it. Slowly all organs got affected. He had foot ulcer which was not healing for about 2 years. Again, I was abroad that time. He was treated in some hospital, operated, and then when I came back, I got him to my nursing home. There, again, he had some chest pain. He went into cardiac arrest. He was revived second time. So, then he developed kidney complications and ultimately 3 years back, he died.
Oh.
So, what I realized is that was very shocking to us, for the whole family. That, in spite of he being my brother, since he was staying at some other place, I couldn't control everything. And probably he was very casual at it. Since diabetes is a silent killer, doesn't produce any symptoms. So he took things very casually, no regular checkup of sugars, no regular checkup, doing investigations. In spite of telling some people they are quite stubborn, they don't want to do. And in fact, he was advised bypass surgery, which he did not go for after second episode of attack. And then, see, that really created something in me that I felt these people, all these diabetic people who lined up in trouble, first of all, they should be aware of it. And lots of complications. With type 2 diabetes, you get 30% people getting heart attack, 28% getting nephropathy, about the same number getting retinopathy. Then you have stroke, which occurs in about 12 to 15% patients, peripheral vascular disease. So, very devastating disease.
It affects everything.
Everything from head to toe. And I felt that though I am treating patient, it is not enough for them to understand the gravity of situation, the seriousness and what they should be doing. So that is the reason I started taking interest after my brother's day. And I have developed special programs for diabetic patients. And I have created a team within my hospital which cater to them, make them understand, encourage them to do sugar charts, continuous glucose monitoring system which can fine-tune sugars. And with that, I find those who are interested, still out of 100 people, there will be only 30 people who will be interested because they don't realize. Even with sugars of 200, 250, they don't have any symptoms. So they are very casual about it. What happened to my elder brother, the same thing I see in the society. So making them aware, taking multiple camps, offering them investigations at a cheaper rate, then educating them. So I conduct webinars to educate them. I have a YouTube channel dedicated only to diabetic patients. Simple videos, nothing sophisticated thing, but my main intention is not I want to become YouTuber. I want to convey message to my diabetic patients. Reach out to their life changes. So this has become my mission that I should be reaching at least 1 million people and I should give them services so that their life changes. Commendable. That will be the biggest reward to me when such things happen. If I can reach that number. And that's why I'm using this social media nowadays. I have started certain specific packages, those who are really interested. We are giving them daily support. And with simple things like on WhatsApp, we form a group. Our medical team is there, myself, my son, Dr. Vijay Chile, then my other RMOs and health coach. We just ask them to take images, photograph of what they eat, just put it across. This is 3 months program and we keep on giving input that this is not correct, start eating this. This is supported by certain clips of videos and we keep on correcting diet, which just change in diet can bring sugars down by 40%. 40. Wow. That is absolutely what we have seen. Then certain interesting things.
Cutting means stopping sugar completely or reducing the amount?
No, we have modified diet in the sense we give very low carbohydrate diet.
Okay. Okay.
See, Indian diet has 70% carbohydrate.
Right.
We bring it down to 40 to 50% of carbohydrate and then increase proteins and certain degree of
Right.
fat. And with that, the reduction in sugar without any medicine can go up to 40 to
All right.
50%.
Okay.
Not 40 to 50 milligram percent.
percent.
So that is a tremendous
Very
power of the
significant.
correct diet.
Yeah. Very significant.
Then we teach them certain exercises. See, we have exercises just for 5 minutes. Somebody does exercise. See, many times these diabetics, their post-meal sugar increases very rapidly. And they are not able to control. Whatever they eat, the post-lunch, post-dinner sugar goes up. So what we do here is, at the end, half an hour after meal, maybe lunch or dinner, what we tell them, just do 5 minutes exercise. These are anti-gravity exercises which are very simple. At the end of 10 minutes from starting exercise, their sugar will drop down by 50 milligram percent.
Oh. Mm-hmm.
Just yesterday only, doctor's husband who was there, basically an engineer, I told him he came down with, he ate pasta and his sugar was 237. He was sitting in OPD for half an hour. I told him, just to motivate him, a young chap, newly detected diabetic.
Yeah.
I told him, okay, what are you ready to do 5 minutes exercise and see your sugars? I will repeat, his sugar came to 207 because he was sitting outside, probably it was started going down. I showed him these are the exercises you are supposed to do, only 5 minutes. His sugar we did again, it was 207. We did exercise for 5 minutes. We waited for another 5 minutes. Repeated sugar. Sugar came down to 127.
Wow.
So drastic reduction. So these are things patients do not know. And I was very happy to see that. And he himself, the patient, was really surprised.
Mm-hmm.
He realized that this is the power of doing exercise.
Yes.
See, majority of the time people have concept of exercise that just do walking, but that is not enough. These are specific anti-gravity exercises which anybody can do.
What do you mean by anti-gravity exercises?
Anti-gravity means you are using, say, like doing squats.
Mm-hmm.
Is against gravity you are moving.
Right.
And you are using large chunk of muscles. These are big muscles which are being used. Similar things can be done in the upper extremities also.
Okay.
And say like jumping jack. And these, what happens is, directly the blood sugar goes into the muscle. When the muscle starts working or getting activated or getting contracted, that is the time the blood sugar starts moving directly into the muscles and the blood sugar drops immediately.
Okay.
So that things like that,
Yeah.
which many times even general practitioners they do not know, or from other specialties, non-diabetologist people, they do not know that. And these can be utilized so we can cut down on the medicines. See, our entire aim of developing this program, 3 months program, is reversing diabetes.
Right. Just on the basis of diet and
Yes,
exercises.
Correct. When I say reversing, the scientific term is remission. When we talk about scientific term remission, indicating their fasting and post-lunch sugars or post-meal sugars are in normal range, less than 100 and 140. HbA1c is less than 6.5. And this remains for 6 months with either minimum medicines or they are without medicines and they are taking care of their diet. They are doing exercises prescribed, reduction of stress, good sleep. All these factors together, they work
Wonders. Correct. Yeah.
See, there is a study by Professor Roy Taylor. Earlier, it was thought that diabetes is a chronic progressive disease. What has been taught to us in colleges.
I remember.
There is no looking back. It continues progressing, continues affecting body, the end organs getting damaged, and it was thought nothing can be done. But last 10 years research has shown, no, you cannot cure it, It will not get totally cured, but then at the same time, it can get reversed. Or a person can go into remission.
Correct.
So that is really
It's a breakthrough, definitely.
correct.
No
It
question.
is the thinking of patient which was there that nothing can be done, and thinking of even doctors.
Right. Of course.
See, the doctors used to think, including me,
Right.
that okay, diabetes may not get reversed. It is a chronic progressive disease, just control it. And once I entered into depth of all this, see, there are people like Professor Roy Taylor from UK. 2017, he has done a study in Lancet, and that is a very remarkable study. Just reduction of weight by 15%, especially in obese people, can reverse the diabetes, or
Okay.
person can go into remission with very low calorie diet, 850 calories per day.
Yeah.
So that then Professor Neil Bernard from US, then you have Jason Fung from Canada, and there are so many studies coming up now. So they have endorsed that reversibility is very much possible. So why just control diabetes when you can reverse it? So now for each and every patient, I tell them your diabetes should be reversed, or we will make full attempt. As a doctor, and our team will guide you. It is your inner strength and your goal setting which will really work.
Correct. Now, about this diabetic reversal, the one thing which I want to know from you.
Yeah.
Now, obviously, once you start this kind of regimen about diet and exercises, you have to continue lifetime.
Right.
For some reason, my diabetes got reversed or under control. My HB1AC also came under control. And after few months of practicing this diet control and exercises, suppose stop it. Is there a rebound effect of diabetic figures and the diabetes if I stop this regimen?
See, there
must be some patients which coming across to you.
Yeah.
They have followed you. After some time, they have not followed you.
Correct.
So what happens to them?
Over years, not only just 10, 20 years, or say decade or so, our diet has changed drastically. Our ancestors used to, maybe 2 generations before us, they used to live a very simple way.
True.
They used to eat simple diet. They used to do exercise, which was inbuilt in their day schedule. Whereas what we do is we hardly do any exercise, all sedentary lifestyle. How much we walk, including doctors. We don't walk at least 10,000 steps or 7,000 steps, and some workout has to be done by everybody. That we are missing. Our diet has changed drastically. We are not taking simple diet. We are taking all processed food, which is the main
Processed food.
Right? Then with that, if people diabetic revert back to all these things, they are again bound to get sugars up.
Correct.
So it is not a punishment diet. See, they can eat sweet, but they should understand. Suppose somebody has the urge of eating gulab jamun. Okay, take small quantity. Eat half gulab jam. It is going to increase your sugar.
Right.
And don't eat other carbs.
Right.
So you have ways out. So to call cheat days. Once in a week, person can have cheat day. So ठीक है, पानी पूरी खाना है, खाओ. वही बात नहीं. And certain things in moderation can be done, but that's not daily. Your daily routine pattern should be healthy diet.
Okay.
And this is not punishment diet, because there are so many recipes which are very tasty.
Right.
See, every day I also take egg gajar, egg tomato, and egg avla. It's a juice. It is very healthy for everybody, not only for diabetic. Where do you get so much of vitamin C, vitamin A, and antioxidants? So I enjoy that, and the taste also is very good. So I feel that our likings and habits should be changed.
Correct.
Healthy ones.
Correct.
And eating other things, our taste buds demand, you can do it occasionally.
Correct.
So that will work. Just quitting everything, the healthy diet, and reverting back to the
it's not
bad diet will not help.
Yeah. Like diabetes, hypertension also is one of the commonest causes for the brain stroke or heart attack. In fact, both of these called as a killer diseases,
Yeah.
and unfortunately, India is leading in both the things, hypertension as well as diabetes. And in fact, India is called as a global capital for brain stroke nowadays because of very high incidence of diabetes and hypertension. Now, one thing which I never understood that brain hemorrhage can be the first symptom for the brain stroke or a heart attack. No? Because as a single risk factor is the most prominent one. Like hypertension, where brain hemorrhage is the first symptom, does diabetes has something which can present as an emergency, like a brain hemorrhage? Or is a chronic disease keeps killing you daily, slowly, progressively? Does it create any kind of emergency like a brain hemorrhage?
No, it is very uncommon for diabetes to present as brain hemorrhage. At least in my practice, I have not seen. But the usual presentations are conventional symptoms: polyphagia, polyuria, polydipsia, non-healing of wound, genital region itching, and fungal infections. Many times, the important part is that diabetes can be totally asymptomatic. And that's where lies the importance of routine checkup once in a year at least. The people screening for, especially people who are obese, those who are sedentary, those who have family history, and those who are having hypertension, high cholesterol, or metabolic syndrome, all these people should be screened very routinely.
When should the screening start? It's a very important question we are discussing. When should the screening start? I mean, you have your family history, you are obese, you don't exercise, or your family history of brain stroke or heart attack, or you have hypertension. Apart from this, any other criteria which will fulfill for a regular checkup for the blood sugar?
I would say these are, of course, the
Commonest one.
indications which are standard ones where screening should start. But now, for each and every person, I feel our earlier generation used to think, when I become sick, I will go to doctor.
Right.
Now the scenario has changed. I feel every person should think how I can remain healthy, fully healthy, and I should not contract any illnesses, and I should live for 100 years.
Right.
It is very much possible in today's era, right? With all science developing so rapidly and so many things which are coming up with transplants,
Yes.
and advancing.
Yes.
So uh, it depends on individual mentality. I mean, but somebody who can afford, why not start doing routine checkup at the age, right from age of 25 years?
Yeah. So, what is that age where you can should start screening for the blood sugar or for the blood pressure even?
I would say even at from 25 onwards.
Why I asked you this question, there is a specific reason for that. There was a census which was done in 2022, and that time they found that 22 million children who are obese were under the age of 5. And India is 11th in position where the obesity is common at the birth. So high is a birth weight. Say we keep saying the birth weight of my baby was 4.5 kg. It is not something to be proud of. In fact, if the baby's birth weight is 4.5 kg, your baby is abnormal. I mean, the baby is born obese. So there are many states in the US where they have started screening for the diabetes at a school going age. At the school going age. So in our country, with this kind of rising incidence of hypertension and diabetes, you think that there is a need to start screening for these two things mainly at the secondary school level? Do you think it will make a sense?
Especially childhood obesity. These people you can start screening at earliest, especially school going children who are obese. So if I'm not mistaken, probably the prevalence is 10% as far as childhood obesity is concerned in India.
Yeah.
And maybe in US it's double.
Yeah.
Now, with that, it is again the adult guidelines. Instead of adult, now you have children. Obese should be screened for diabetes. People with sedentary lifestyle, sedentary childhood, that children are not playing. They are just watching the mobile and all indoor games.
Digital technology.
Yeah, all just coach potato.
Yeah.
Thing like that. These people obviously are going to get illnesses faster.
You're right.
So I would say that it is highly individualized.
Mm-hmm. Mm-hmm.
One is if you screen so many patients blindly without identifying who are prone to develop diabetes, probably it will not be cost effective. But for people who are like, as you said, a child who's obese, you should definitely test even lipid profile. His BP should be checked. His sugar should be checked.
Correct.
Because for that child, it is going to be 100%.
Right.
So how much is going to spend? Not much per year.
Right.
So those who are predisposed to develop diabetes and all metabolic illnesses, these are the people who should be screened at early age, the moment they are having obesity.
Correct.
You should first of all resolve that or treat it, and you should start screening them at that age also. Because
Correct.
I have seen familial hypercholesterolemia at very young age. That is, of
Right.
course, though the genetic part of it is there. But then otherwise also you see screen anybody at the age of 25 years, you will find LDL going up or triglycerides going up. So those who have higher triglycerides, ultimately they are the people who will get diabetes.
Correct. In your practice, how often you see children with diabetic?
Uncommon. See, the juvenile or type 1 diabetes is not so common.
Okay.
As has been described, it is less than 5%.
Mm-hmm.
But there are juvenile diabetes patients coming to me, not in great number,
Okay.
and they are obviously on insulin. And then there are so many other types of diabetes.
Mm-hmm.
See, earlier in our college days when we were taught, it was only type 1, type 2 diabetes.
Right.
Now there are so many things. There is an entity called monogenic diabetes. Then you have other entities like you have MODI, maturity onset diabetes of young,
Okay.
which is again has genetic predisposition, and there are 5 types of that. Then you have latent onset autoimmune diabetes, and then there are pancreatic calcification and other diabetes. So it was our idea that it is type 1 and type 2. But if you go through the classification, there are various other types, though they are not big in number, but they are there.
They are there.
So it's not blindly that we cut off from type 1, type 2. There are intermediate things which are come.
So they are classified, even the treatment is different for them.
Treatment does
Some
differ.
extent.
The outcome, yes, to a certain extent, it does differ.
Yeah.
And the outcomes also differ because
Right.
some will respond to things like biguanides, and some will respond only to metformin
Right.
and sulfonylureas.
Mm-hmm.
Some who will respond to sulfonylureas faster.
Okay. Okay.
So these are different types of diabetes which we need to understand.
Right.
As a practicing physician or diabetologist, it's not always one or two.
Yeah. Now, you told me that your interest in diabetes actually came into picture after your elder brother's sad ending. Now, I want to ask you something which is very personal. Now, your elder brother knew that you are a MD physician, right? He had a help at the fingertips. He just one phone call and medical help was available. And though you were the first doctor in your family, but I mean, they had a support of a doctor and also that too MD doctor. So, what was the reason that your brother did not follow your advice? What I want to ask you that if this can happen to a doctor's family, what must be happening to people where this kind of medical advice or medical help is not readily available, which is very common in our country, very, very common. So, what must have led your brother to think that I should not follow what Vijay has told me? What must be the reason for that?
Very important factor as far as these differences exist is the how that person's personality is and what is his mindset. You will find in your own practice also people who are very meticulous. They will look at all, they will keep on doing investigations every year without having any illness. And they will go to doctor, come to us and show the reports and try to ask the minutest thing, something which is probably not significant, why this is happening. And there are people with 4 illnesses, they are just not bothered. So these are the differences in their thinking about their illnesses. And
Just the attitude, basically.
it is the attitude. Okay. So the some of the people, they don't know. And some of the people, after knowing also, they are not bothered. So that cannot be eliminated totally. So even if I am just phone call away, after without phone call also, when I am telling, the things are not followed. And that's why what we require is a motivation. See, it's not only the science here, it's the we have to really make them understand and remain after them. Ki you have to do this for your health. And why you are not doing it? Why do you want ill health? Why do you want to undergo bypass surgery? Why do you want to be on dialysis? We have to make them afraid. And I will tell you story of a young engineer who came to me. And yes, must be 26, 27 years IT engineer. And very sedentary activity, a lot of junk food. And then he developed diabetes. He was so shocked that nobody in family having diabetes, how I am having. And whenever somebody who's shocked and afraid of diabetes comes to me, I'm very happy. Because this is a person who will follow what I'm telling.
Okay.
Very big difference. My brother was overconfident. Anything happens, you are afraid of. My brother is a doctor. So earlier he had experience. But instead of making him understand, ultimately, if your sugars are elevated, your body is going to get damaged. But that attitude of not caring much, I'm not having symptoms, I'm okay, my brother is there. So that's why we started with certain different approach. It's not a consulting practice. Take these medicines, take this diet literature, see my YouTube videos. There is something beyond that. So somebody who is interested with, they just give them something extra, whereby they will understand. And at times we make them follow like hand holding and making things do. They should be doing all this thing. Have you done exercise? Yes, put the video. How many steps you have walked? There is a app, Google Fit app. Steps are counted, your heart points are counted. Just put it. So that accountability is the thing which works really. If you make them accountable, it is easier many times for patients. Our near and dear, at times they don't listen to us.
Because this is a very important part of a therapy. Just by telling them, you take this diet, you do this exercise, you take this medicine, this motivation to get better, the motivation to remain healthier is the most important part which is lacking in the therapy.
Very.
If you see in today's practice, if you go to any consultant, they are so busy, I mean, they just write the treatment, but we don't think whether this treatment which we advise will be followed up by this particular person. So unless and until I motivate them or maybe sometimes threaten him, it is not going to happen. And that is very true for the brain stroke, heart attack, because these are the things which are related directly to unhealthy lifestyle, directly relation to the unhealthy lifestyle. And if I tell somebody that you don't have burger, you don't eat fat-rich food, you sleep well, don't take your mobile into a bedroom, don't waste time looking at this, nobody will going to listen to me unless and until they are motivated. So that's the main important thing that we are finding uh, a big obstacle in when you create awareness about a brain stroke. Yeah. Now,
Sorry to interrupt. Yeah, in this context, what I would like to say is many times it's not, if somebody sees my prescription, they get surprised that I'm writing names of the books which motivate people, like Atomic Habits by James Paul, because I am fond of reading a lot of books. And it is our personal interest to what extent you want to develop yourself and do the things. So since I have that like think and grow rich, how they tell you to set up a goal, strong desire, then massive consistent actions, then masterminding. So all these things which are for earning money or setting up industry or something are same thing are applicable for our personal health also.
Of course.
So people have to, if they read something like that, then they get motivated. How you can cultivate ultimately this into habit, that you don't have to think कि मेरे को exercise करना है चलने का. 7:30 you are going to go for walk, and that is your everyday routine schedule, like you are taking bath, wearing clothes.
Whatever minute happen, you have to be there.
Correct. This workout time, 10 minutes workout, you are going to do that. You are going to, in fact, my breakfast, if the things which I give, diet which I give to patients, it will mention there are 5 compulsory things in the breakfast you are supposed to take, which is many a times common for most of the patients. Take soap, methi seeds, and many of these are from Ayurveda.
Okay.
Or from the diet,
Yeah.
actually. That take soaked methi seeds, 1 teaspoonful in the morning, because methi has properties to lower sugar. The second thing, take sprouted moves or take any sprouted pulses which you like, 15 grams, then gradually increase to 30 grams. Then third thing you need to take 1 tomato, 1 carrot, and 1 amla. Make a good juice of that and take it. Then we have healthy smoothie, green smoothie. I have given recipes also. So for palak patta spinach, काली मिरी 4 टुकड़ा, दालचीनी 1 टुकड़ा कूट के, half pear, small pear or half apple, use बनाओ. Gut cleansing action, virachan, as we say in yoga.
Yeah.
Then you can have 2 boiled eggs for non-veg people without yellow, which will give you 14 gram first class proteins. So this becomes your fixed menu. और उसके बाद में क्या खाने का है, वो आपको इडली याद आता है तो उड़ीद दाल का इडली एक खाओ, क्योंकि इससे तो पेट भर जाता है. इससे पेट भर गया आपका, उसके बाद में आप कितना ज्यादा नहीं खाओ.
Don't have to eat more.
So this is a trick which we tell them कि ये आप करो. So then it doesn't become difficult. कि एक वो habit लग गया. At the end of 3 months they will not feel like eating अरे वड़ा पाव खाओ ये खाओ बार-बार, क्योंकि फिर वो somehow the body and the thinking mind also start thinking in a different way. Once you have developed those habits.
Right.
I said, right, something like that.
Yeah. No, very interesting, extremely interesting. When you treat these patients with brain or heart attack, do you find any financial constraint while treating these people? Suppose you get a patient with brain stroke and you want to thrombolize the patient.
You're right.
So does the finances come in the picture?
Yes, very much.
Very common.
See, as your initial question was, what are the difficulties in your area?
Right.
So first of all, when we are talking about stroke, they are not aware that they should come to doctor very fast or to a setup which is enabled for thrombolysis. So they will first of all go to any doctor, any GP or any their doctor known to them. The second thing, they do not know the importance of time, that this is the golden time, that earliest you go to doctor, the things, investigations can be done fast and you get opportunity to get thrombolyzed and recovery. So that is not naturally, but because they are not medical people.
Correct.
Then so many of these patients, they come very late. I would say almost more than 90% patients.
Right.
So that treating window is lost. Then these people, many a times, financially, yes, they are not everybody is affording. But fortunately now the cost has come down, and with 10 hectoplasm 20 also we can thrombolyze. So that is, earlier it was TNK costing more than 60,000, 75,000 about. So that is a good part, that it is available at lower cost. But then some of them, they are from very poor category, so they don't have enough finances. even if they come within window period. So that such problem we do face. And then we don't have other options. Either send them to the nearby center, which is the government hospital, but government hospital doesn't have all these protocols. Okay.
Mhm.
So nothing much can be done for them.
That's a very sad part. Yeah. Very sad part. In your area where you practice, how many people must be having the medical insurance?
Having
Insurance, health insurance?
uh, health insurance is not in many, but good thing about it that people are now aware and they have started taking, especially middle class people. They are very well aware and they opt for policies, uh, medical claim policies. The lower class still it is not there. So lower class, middle and upper middle class, they go for policies most of the time. The lower class is difficult. The percentage of people taking policy is not big.
There was recently a paper published by one of the leading insurance company, that if you remove the corporate insurance, I mean, people who are working in the corporate sector, the number of people who have medical insurances in India is between 7 to 9%. Just 7 to 9%. Yes. That is a very, very sad set of affairs, which I never understood this concept. I mean, when I buy a two-wheeler, when I buy a car, you know, उसका इंश्योरेंस लेना ही है. By default, we buy this. Because unless and until you buy the car insurance, RTO will not give permission to drive on the road. This we do for the car. This we do for the two-wheeler. I take a mobile, I take a insurance so that my mobile, something happens to my mobile, it should be insured. Why people don't buy insurance for their own health? This I never understood. I mean, for a mobile, if I'm buying iPhone, which is about 1 lakh rupees, or any other smartphone, I buy insurance for that digital gadget. But why I don't buy insurance for my own health?
See, the simple remedy for that is government should make it compulsory even to private factories or private industries.
I'm not talking about government. Government cannot really force you. I'm talking of that why you yourself are not bothered about your own health.
That you don't think. It will remain like that. See, simple solution is government makes all, of course, for government employees they can make. For private sector also, if they make that the person who's running industry makes it compulsory and cuts some portion from the wages, from the salary.
That happens in corporate sector.
But not all corporate sector, I would say. See, they're
all, not all.
These are prominent. See, big companies are obviously going to give that facility to their staff. But then small industries, you will hardly find that is not.
It's a very sad set. What happens that when patient walks in your clinic, who can be cured of a disease, but just pure you want of money, you cannot treat that in a private sector. You have to really push him to a public sector.
See, that is a very sad mental setup of our Indian people.
That's very sad,
In fact, what I would say, it is one step beyond that is people are ready to go to restaurant and eat and pay a bill of 3,000 to 4,000 just for simple dinner of poor people. But when it comes to doctor, medical expenditure and for their health,
they will not.
They are reluctant because that is the apathy, or they have no interest in their health, or they think that nothing will happen to me.
I never understood this psychology. And I suppose that exists everywhere, Now, you have spoken about diabetic reversal, and it's a very, very interesting topic that we really covered, Now, one thing that you had mentioned that you also do chelation therapy for heart and their strokes. What is it about? Can you elaborate on that?
I used to do it. I had interest. In fact, there is a story behind it again.
Yeah.
1989, when I joined the company, the Ramsi Murari Chemical Company, and the chairman had come across this book, Bypassing Bypass. And there this chelation therapy was described. And then he asked me, why don't you go to UK and study that? The company sponsored me. I went to UK. I studied that in 1993. And then I started practicing it.
What is chelation therapy first?
Chelation therapy is giving EDTA intravenously and giving certain electrolyte, taking care that person has no renal failure and removing all those contraindications, and then giving it for reversal of coronary artery disease. Let's say suppose somebody has 80% block and please advise that person should undergo angioplasty or bypass surgery. So those who do not want surgery, of course, surgery is the first choice, say for triple vessel disease or left main disease. But they, for some reason, person doesn't want it. Or somebody who's advised angioplasty, rightly so, that is the scientifically proven strategy or treatment. But they do not want it. Then this is another option in addition to whatever medical treatment is going on. It is no substitute for the standard indication. It doesn't mean that you don't require bypass surgery and your 80%, 90% blocks will dissolve and you get 30% block. There is nothing like that. It is basically endothelial stabilization with EDTA and certain constituents. So that is the main thing. I used to practice, then we couldn't get EDTA. Earlier we could get it from UK. And so I stopped it long back because many people have sprayed those who are practicing chelation therapy. No, you don't have to undergo angioplasty or bypass. This therapy can be used and you will not require it, which is
how successful was it? I mean, did it really replace bypass and angioplasties that time?
No, it is not replacing, but those whom I had given, these are people who remained symptom free for very long time.
Okay.
So it has a substance in it. Now,
those patients were actually eligible for some kind of intervention,
correct,
angioplasty or open heart surgery. Correct. And those did not undergo any of this procedure because of this therapy. Correct. Why it is not practiced so widely in that case now? Is it because of this complex medical industry?
There is what you require large trials. EDTA is out of patent.
Okay.
Nobody is going to get anything.
Okay.
So no pharma giant is interested in it.
Not.
So I'm not saying that means that EDTA is definitely better, but unless there are big trials, the final word is not going to come.
Okay.
So you have to have big trials and then definite data, random multicentric trials. And when these trials are not existing, we cannot just say or FDA is not going to approve it.
Yeah.
For this. But personally, in small number of patients in whom I tried, I found it as substance. It is not 100%,
Okay.
but no medicine is 100% that way.
Right.
So even if it is making 50% people better, it is worth doing it.
Is EDTA available now in India?
It is available now.
It is
available, though I am not practicing it because of the the bias and the wrong impression which has been created about it by people who are practicing also, and per the perceived impression of chelation therapy.
Correct.
So I am not doing it. But then I personally feel there are so many therapies which we should not just discard just because we are practicing allopathy.
Correct.
They are very useful.
Yes.
Like hyperbaric oxygen therapy.
Correct. There is another area of interest that you have, hyperbaric oxygen therapy.
Like
do you have these therapy centers in Namana?
I had it earlier, but then
You also had it?
Yes.
Achha.
See, in 2010, I got first hyperbaric chamber, which was installed in Thana, which is still there.
Okay.
And then we bought second one, and that was installed in my place. But then I didn't have later on the place, so it was shifted to another place, and then this was dropped.
Okay.
Because I didn't have manpower to manage it. But there are already 14 standard indications of hyperbaric oxygen therapy. Some of the miracle things which I have seen about hyperbaric therapy, which I would like to share.
Yes.
The chamber was installed at our place, and then there were 3 to 4 people who came with uh, there was a fire and there was a lot of smoke. They came with carbon monoxide poisoning, and this is the prime indication for hyperbaric therapy. They were in a drowsy state, not able to walk properly, and one of the patient who just was, we had to hold him with support. He was given hyperbaric oxygen therapy for 1 hour. At the end of the therapy, that patient became fully alert, started walking, no giddiness, nothing. He improved dramatically.
Wow. Uh-huh.
So that is my first hand experience right in the beginning when I started. So these are certain things where it is strongly indicated. And of course, for divers and even the Navy people, they use at Ashwin. And other thing is the central retinal artery occlusion.
Okay.
So if given in 24 hours to 48 hours, the ideally in first 24 hours, the results are very good.
You had such cases in the past?
I didn't have first-hand information, but then there are all those colleagues with whom I talked. They said this is one of the prime indications.
Okay. And that's a very time-dependent treatment.
Very
Within 24 hours, we have to start.
Yes. Earliest, as early as
possible. Anything else where HBOT is proven to be effective, apart from diabetic infection, diabetic ulcers, or bed sores for that matter, or long-standing chronic lung infection? Anything other areas where you like to recommend HBOT?
Acute sensory neural hearing deficit.
Okay.
These are patients where we get patients from ENT.
Okay.
And I have seen 50% improvement within 5 sessions.
Okay. Like Sunday vestibular neuritis or Meniere's disease.
They just get hearing loss. These ENT people label them as acute sensory neural deafness without any cause. Maybe the edema of the nerve or
They respond.
whatever the cause. But they are the one who which respond.
Anything which is any kind of relate to brain or the heart, where HBOT can be used.
Brain, yes. Brain, see, in primary ischemic stroke is not a standard indication. But whenever there is a brain swelling, cerebral edema, hyperbaric works very well. Even in the stroke patients we had given, taking consent that though this is not a prime indication, and they improve definitely, say by 10-20%. There is no dramatic improvement, especially in patients who have aphasia or dysphagia. These are patients where I have found their speech improves. So these are our observations.
I have a primary evidence. I mean, in patients of head injury, which were brain dead, they received hyperbaric oxygen therapy, and after taking treatment for a month or so, almost a month and a half later, they have walked home. We have such cases. I mean, they were brain dead with a large clot. I mean, we told the relative that there is no doing anything for these people because he's brain dead. There is no point in doing even surgery for these people because he's brain dead. But we were forced to operate, and then they were given hyperbaric oxygen therapy, and they have improved well. I mean, role of HBOT in trauma is well known, and that is been practiced decades. But also, we have few patients with acute brain infarct. Once the treatment of thrombolysis is done, once they're stable, we have referred them for HBOT and they have shown remarkable improvement. Again, this is there is a difference from case to case. I mean, I cannot make a generalized statement saying that brain stem infarct will go home or a large hemispherical infarct will improve. I'm not saying that. So you really have to choose the cases and then advise hyperbaric. But hyperbaric does have a role in many conditions. And as you said very correctly, no one single treatment is beneficial. And you can say without an hesitation, this is the best treatment. For most of the diseases, unless and until you combine different modalities, I think that holistic approach is required. for this thing. Otherwise, it is very, very difficult. I mean, there is no one magic pill for any disease. It has to be combined with many other things which are non-medicinal. Like as you said correctly, diet control, regular exercises, anti-gravity exercises. I think you really got to choose your right card, for any particular disease.
Right. You must have seen more head injury patients, obviously, because you are a neurosurgeon. But I remember certain subset of head injury patients who had trauma and they are remaining drowsy, mild cerebral edema, managed with all anti-edema measures. They are not improving further, and nothing to operate upon. These are the patients who were given HBOT and they improved dramatically.
Yes.
In
Completely.
before sitting, they improved.
Yeah.
That's
Totally.
what I remember.
Yeah.
But I'm not actively managing now.
No, even now, also in our practice, head injury patients have reduced in number because most of this trauma now gets trapped in the periphery. Very few people are coming to the bigger hospital. No? Vijay, this today's session was really nice, and I'm very happy that you came here and we had a good discussion on diabetes. What I understand,
Pleasure.
yeah, from your talk today, that diabetes is a silent killer. There is no question about it. Like brain hemorrhage, it doesn't present as an acute or emergency. It doesn't create an emergency, but it kills you silently. And it is a multi-organ involvement. It doesn't affect just one organ. Like a hypertension affects all the organs. And a most important message that has come from you is diabetic reversal is possible, which many people don't know, and for which you don't have to spend millions of dollars. Just little control in the diet, little exercise, and most important than your attitude towards the particular disease, and you need motivation for that. And it's a great work that you're doing as far diabetic reversal is concerned. And I must congratulate you for your new book. It just got published. Yeah. Keep doing nice work and keep coming to us for the podcast. Thank you so much for coming here.